welcome to the Carcinoid Cancer Foundation's Facebook Live series. And this is another one of our special events that we're doing on a weekly basis now about the COVID-19 or coronavirus pandemic, because we're all concerned, but especially NET patients. And so first of all, I want to thank Lexicon Pharmaceuticals for making this possible. They're our presenting sponsor for this weekly COVID-19 Facebook Live series. My name is Rain Bennett. I'm a filmmaker. I've been working with Carcinoid Cancer Foundation for about 10 years now to create video content to raise awareness and spread education on neuroendocrine tumors. And I feel honored and privileged to be a part of this community, which is a very strong community, and it's very fulfilling work for me. So this is something I really enjoy. If you have tuned into any of the previous Facebook Lives, you may recognize me. If not, hello and welcome. And since you are here, as we're having people log on now, we see the numbers are growing. Let us know where you're signing on, where you are in the world. We love to hear how far we're reaching and where we're impacting people. Today, our guest is Dr. Mary Maluccio. How are you, Dr. Maluccio?
I'm doing great, Rain.
Thank you so much for joining us. Could you tell the people just a short bio? Let us know, how did you end up in this world of neuroendocrine tumors?
So, Rain, I am originally from San Francisco, California.
Okay.
I did all of my medical training in New York City, and then I spent the first 15 years of my professional life in Indianapolis, Indiana. And I am a surgical oncologist by training, but that my professional niche is actually in cancer programmatic development, which is sort of how I got into the neuroendocrine world. And what I mean by that is that you will take a disease or a very particular patient population, and you will build a family of professionals around that disease in order to take care of what can be very broad needs of a particular patient population. And for some cancer programs, that could be 3 or 4 medical subspecialties, but for something like neuroendocrine, it can be 12 some odd subspecialties, and include providers that don't actually spend all of their life in cancer care,
right, that
are really important, like interventional radiologists or nuclear medicine radiologists or gastroenterologists or endocrinologists or rheumatologists. And so it's not just really about the medical oncologists, the surgical oncologists, and the radiation oncologists. And you can bring all those around kind of with a common purpose. And I think when it works well, it really raises the level of patient care well above anything that any of those individual components could do on their own.
Now, this is something I'm really interested about, and I've been learning a lot about this year, especially with the work I've been doing with CCF. Why is it so important to have a team, or I love how you said a family like that for this disease in particular?
Well, one, neuroendocrine is really not just one disease.
Fair.
It's a variety of diseases that can influence the lung when it comes to lung neuroendocrines, and then almost the entire digestive tract from the brain down to the backside. And so each of those individual patient groups will have unique challenges, and there are many favorable aspects of the disease, and there are many unfavorable aspects of this disease that need multi-provider input. And then another thing that I think is really important is that I have focused my professional life on marginalized patient groups. And those are patients that are sort of pushed to the periphery of mainstream medical practice for a variety of reasons, commonly poverty or your access to healthcare. But the rarity of a tumor makes you a marginalized patient group because your outcome is actually dependent on your ability to find providers that are comfortable managing some of the complexities of neuroendocrine. So we have probably failed to a certain extent to come up with clear standards. I think we've gotten a lot better probably over the last 5 or 10 years, but come up clear standards. So it's just nothing's easy. So the checks and balances of a multidisciplinary program, I think, are more important in neuroendocrine than in almost any other cancer subtype.
Thank you. Thank you for clarifying that. Okay, so everybody that's tuning in now, we're getting our numbers up there. We appreciate you joining us. Let me give you a little bit of some details about how it's going to go down today. Today, we're specifically talking again about the COVID-19 crisis and how it applies and pertains to a NET patient specifically. So, ask your questions, ask away. We're going to try to get to all of them. We already have a few questions banked up from the social media posts that we put out earlier this week. But we're going to try to get all your questions. If we don't, I encourage you to follow up with Carcinoid Cancer Foundation, either here on the Facebook page or at their website, carcinoid.org. And hopefully they will direct you to the information or the specialist that you might need. So ask us your questions. We'll try to get to all of them. We have a little disclaimer from the sponsors that we want to say up front. The opinions expressed by the guest presenters, that's Dr. Maluccio, as well as the questions asked by the audience, that you all at home, have not been created or suggested by the sponsors of the Facebook Live program. And CCF doesn't endorse or promote any of the views, opinions, or information provided in this presentation. And audience members should not rely on the opinions and information expressed and should seek guidance and direction from their own medical advisors regarding any choices they make about their health and treatments. And so I always like to clarify that. Basically what that means is we're going to hopefully give you a lot of valuable information today, but by all means, your plan still needs to stick with your own healthcare provider. And Dr. Maluccio can elaborate on that if she wants to, but stick with your team and listen to what she says about the multidisciplinary team. I always, encourage people to be their best own advocate, but stick with your team and make sure they're aware of everything that you're doing, and you make the plan together. Before we get started, Dr. Maluccio, any words you want to add to that?
No, I completely agree with that. And I do want to reassure people that although medical providers may use slightly different words to describe the same situation, the message it should be 1 degree of separation from the same. We just may have different ways of describing it.
Got you. So, and one last thing, everybody at home, we can't get to super case specific questions. Obviously, Dr. Maluccio is not your doctor. So if the question is too case specific, we'll try to answer in general terms, or we may ask you to rephrase in a way that we can still give you some good information. But if she's not your doctor handling your case, obviously she can't answer in too much detail specifically to what your experience. So we already have some questions. I've noticed that since we've been doing these COVID-19 Facebook Lives, we have a lot of the same questions that come up. And so if you join later in the video, I would encourage you to go back to the beginning, because I'm going to try to lay some of the groundwork, some of the foundation, and go ahead and address some of those questions that we've been getting a lot of. So one that I hear a lot is, as NET patients, as everyone right now, we hear this term immunocompromised. That's been thrown around a lot in the media. And so many people aren't sure what that means, but for NET patients, they want to know, is that me? Are we, since we are NET patients, immunocompromised?
So I think that is somewhere where the information is somewhat confusing. So immune compromised is just a broad term to describe people that would be unable to fight off infection in the same manner that an immune competent patient would be able to do the same. And so cancer patients then fall into that group, but it's really particular cancer patients that are on active treatment for which then the immune system is suppressed for a period of time or for a longer period of time. And so I think that many of the other guests have also said something very, very similar to it. So you could be immune compromised because of medications that you're taking, or other medical conditions like chronic obstructive pulmonary disease, Crohn's disease on steroids, diabetes, asthma. So there are many things that will influence your ability to mount the same immune response as someone without those conditions. So when people say that NET patients aren't particularly more or less immune compromised, it's because you have an entire subset of NET patients that are not on active treatment that targets the immune system and suppresses it to the point where you wouldn't be able to mount the same response as a normal individual. But there will be NET patients that are on treatment or have other medical conditions that will influence their ability to manage that infection in the same way.
Got it. Got it. Thank you. Are there certain types of neuroendocrine tumors like lung nets that would be more likely to get COVID-19?
So, yeah, so you bring up a good point because it was brought up on your other Facebook Live. So the risk of getting something is the same for all of us. So the risk factors associated with exposure. What is different is how each individual is able to mount a response to that exposure.
Got it.
All of the recommendations are the same regardless of where you fall into that group. So NET patients, cancer patients are no more likely to get this than they would to get anything else that is roaming around in this grand world of ours.
Okay.
Difference and why we have particular precautions to immune compromised patients or patients with comorbidities or patients in higher age groups is because we have no treatment. We have no vaccine. And therefore, if you were to be exposed, then you are in a higher risk group to having a worse outcome or having a harsher set of symptoms. So the guidelines that we're talking about is just trying to diminish exposure in general, trying to eliminate that as a variable. So no, the answer to your question, which I don't believe was answered with as much certainty last time, was that we are no more or less at risk for getting it. It is how we are able to fend it off.
I love that, and that makes it very clear for me to understand. So, because people, a lot of our patients are asking, are there other steps or other things they should do to be cautious? And it seems like what you're saying is that no, abide by all the guidelines they're putting out there and be even stricter about it, because you're really in jeopardy of the consequences if you get it, not how easily you will get it.
Yeah, I completely agree. That is
okay.
Is what I meant to say and what I said. I think another thing that hasn't really been addressed is that much of the exposure is unintentional exposure. It's not as if you have people with a known exposure going and coughing on all at Costco. And so it's the unintentional exposure and the fact that the symptomatology can vary and be very mild in children. So we are accustomed to children having a runny nose, running a fever, things like that. And the first thing in our mind isn't all of a sudden that they have COVID-19. But because their symptomatology can be so mild, they will be unintentional carriers. So that's why we tell older age group grandparents that now is not the time to be hugging your grandkids, not because you don't love them, just do the Facebook Live thing going. But that and that's why we sent people, kids home from school, is because it just ends up breeding in there and of very little consequence to the vast majority of kids, not all kids, but very consequences in that age group. But that it is that age group that tends to also, hug a lot, touch a lot, spit a lot, stick stuff in their mouth, and therefore it's hard to control that aspect.
Definitely. Yeah. I have a 2-year-old daughter, just turned 2 last week, and it's tough for all of us. We had to sing happy birthday over Zoom with the family. But it's definitely for the greater good. But I hear you in terms of what they put their hands on and put in their mouths, and that's a tough one. Okay. So next question is, should I have my monthly injection or can it wait? And if so, if it can wait, how long is reasonable?
Okay, so that's also a question that I thought has been answered really nicely, previously. And so since Dr. Chowan was on last time, the Ipsens and Novartises did step up to the plate and expand greatly the ability of people to get their injections at home. So I do think that if you don't disrupt as much of your life, then you won't have the added burden of wondering with that uncertainty. I would just get it if it is not an unreasonable or a significant burden to get it. But I also would be as confident as your other speakers in saying that for the most part, that is a drug with a very long half-life, which we know that skipping doses or delaying doses for whatever reason is not going to be a deal breaker or a deal maker. Someone did, though, mention in people that are symptomatic, where they are on that medication to control a very severe carcinoid or neuroendocrine syndrome, well, then I would reach out to your neuroendocrine providers, and we would do everything in our power to reach out to the pharmaceutical industry and be able to get those patients the medication that they need to control their symptoms. And so it is patient specific, just like your other guests have said. It's very patient specific, but I wouldn't be worrying about it if it's just a monthly injection for you. And it's your worry over the consequences of missing that with respect to your cancer, because there are few, if any, consequences to missing a dose.
Got it. Well, everybody out there listening, I see that our numbers are continuing to rise, which makes me very happy. And Dr. Maluccio, I can tell that she's excited. She wants you all to come join us. So if you are just signing on, let us know where you are in the world. Tell us hello. Give us a thumbs up or a heart emoji. If we're doing a great job, we are here to serve you. And Dr. Maluccio, there's a lot of people coming on now, and to those people in the audience, Dr. Maluccio has referred to a couple of other sessions that we've had. We tend to do these monthly about different net topics, but lately with the COVID-19 crisis, we've been doing these weekly. So she has been referring to some that we've done before. If you haven't seen those, they are on the Facebook page. But in the meantime, Dr. Maluccio will do her best to give you all the information that she can here. Dr. Maluccio, they may or may not have seen the previous ones. But we thank you all for joining us. Go ahead and send us the questions in the comment box, and we will do our best to get to them. Let's keep moving forward. Dr. Maluccio, okay, this is a question I've gotten before too. How can I tell the difference between net diarrhea and stomach issues and diarrhea and stomach problems that may be due to the virus? Or is that something that people with the virus experience?
Okay, so that's actually a very good question, because there are always sort of overlapping symptoms. And so patients that have had neuroendocrine syndromic type symptoms will tend to understand those symptoms, but that they can often worsen over for a variety of reasons, including viral illness. I would say the big difference is the fact that this, especially in the adult population, is usually associated with a fever. So that's why we've gone to such great lengths in China and in Europe, with the temperature checks as sort of a sort of entry-level surveillance to see whether or not someone has potentially got mild symptoms but is having that fever. It's also associated with respiratory, issues. So when it's affecting you, it's usually upper respiratory. As you mentioned previously, it's sort of a dry cough, not one that is typically like you're coughing up a lot of junk like we have with other types of viral illnesses. And yes, diarrhea and intestinal discomfort is also one on the list of it, but it's not a mutually exclusive one.
Okay.
It's like people say the only thing I had was diarrhea. And I'm sure that there are people out there that have tested positive and only had that. But in general, I wouldn't take that as a single variable to suggest that you have it or have not. And then if there's any question in your mind, then I would just take the added precautions of isolating yourself somewhat more from the rest of your family group.
Got it. What about net patients who were or are scheduled to have surgery in the next few weeks?
Yeah, so that's probably been one of the toughest questions, because a lot of the neuroendocrine tumors that tend to be slow growing would fall into a category that I suppose we have the luxury of waiting.
Mm-hmm.
Recommended 30 to 45, which is probably going to be closer to 8-week range, without having a detrimental impact on your cancer specific outcome. So, as other people have said, it has to be a case by case basis, because in people that are symptomatic, obstructed, losing weight, malnourished, then that same 8-week period of time is going to leave them weaker, somewhat more immune compromised, that can ultimately weigh into their ability to recover from the very operation that we're waiting to do.
Right.
So I do want to be clear with people that no recommendations are suggesting that we not operate on anybody.
Okay.
They're saying that we look at it using a window, saying, well, is it reasonable to try to diminish any unintentional exposure by bringing them into a hospital right now and doing an operation and making them immunocompromised, this versus can we reasonably wait? And in our clinic, we have several people that are sort of out in that limbo zone, and we check up on them every single week to make sure that we are not pushing the limits of what is reasonable in those patients. But we are not putting off all surgeries. If they are urgent or emergent, they have to be done, and waiting would be detrimental. But if they can wait, this is the one type of cancer where waiting is often not associated with the same type of detrimental outcome as it would if we were talking about other GI cancers.
Got it. Thank you. That helps. What about PRRT? If that's scheduled, let's say next month, we're in April now. So if I were scheduled to have PRRT in May, should I have it? Should I wait?
So PRRT is also something where we've looked at the same type of window, but we do use that window much liberally. Okay. So one of your guests, I think, described the fact that built in to the data that actually drives the use of PRRT in a particular patient group had a plus minus of like 14 weeks, but that obviously built into the trial are reasons to delay that were required. Someone didn't have their counts bounce up, or they didn't recover between treatments or whatever. But still, all the same, the data is the data, is that the progression-free survival benefit that's associated with PRRT has that built in to what actually happened in that trial. So we have delayed a lot of our PRRTs. We still do treat the people where we feel that the progression of disease is not one where we felt that it was wise to wait the 30 to 45 days that we were looking at when we were making these decisions a month ago, but that we did push out most of all the ones that we could wait. We did push them out the 30 days and then said we would reassess at that time.
Got it. Okay. Last general question, and then we have a good bank of people that are asking their questions. Now, if I have metastasis to my liver and get the virus, will this make the tumors in my liver grow, or will it affect them in some way?
Well, that's actually a really good question, of which we don't know answer to that. So, there is certainly data out there that would suggest that, like Dr. Chauhan said about nutrition and about good nutrition and poor nutrition or whatever, and that cancer is living off of your protoplasm, your entire your body is your temple ring. So viral illnesses in and of themselves will cause alterations in your immune system, will ultimately immune compromise you, and so the downstream consequences of it and how a cancer uses that to its advantage is sort of unknown, but has certainly kind of been tested in rats when we do malnutrition studies or we take certain nutrition stuff away, or we do them in immune compromised mice. So we know that happens, but not that it's going to change then anything other than the recommendations, which is that you have to be super diligent. You are on any higher than average risk group, but not more diligent than doing anything that is other than that is recommended by, that all of us should be doing, but that those of us that are not in the same position have ever so slightly more leeway about maybe going to the grocery store. You know what I mean? And so, no, I would not say I have convincing evidence that getting this virus is going to make that person's tumor cells, grow at a faster rate or take advantage of that environment. But it's not like it's a completely illogical thought that anything that would affect the overall condition of your body would not affect how a cancer behaves in that body.
Got it. Thank you. Clifton asks, if a patient decides to skip a shot because of COVID, is it better to shorten the missed time to 2 weeks and to create a new schedule than to wait the full 4 weeks to resume treatment and continue the original schedule? Does that make sense?
Oh, I would say the schedule is the schedule. I don't think that you have to resume it on the previous schedule.
Okay.
Is that I would just say that once we come out of the woods a little bit more, and infusion centers or wherever that the person is getting their shot has a more method, whether or not it be a testing method or whatever. I mean, we're getting a lot closer to the end of the tunnel, right? Mm-hmm. And so you would just resume a schedule that is when you get that, that dose whenever you get it. And then you would start back onto a Q28 with a new schedule.
Got it. Okay. This is actually a question from John, who I've heard this a few times. Is there an increased risk for someone who's had a left lower lobectomy? And so we've already established that there's not an increased risk in getting this, right? So I guess the question is, what are the risks for a person, if there are any extra risks, that has had a left lower lobectomy?
Right. And so I actually do think that is a very relevant question, but not necessarily from just a lobectomy standpoint, but because of lung disease, history of smoking, it's going to be that would affect the quality or the quantity after a lobectomy of one's lung function. Right. And we have the same issue in liver surgery, because we will often do liver surgery on people with metastatic cancers, including metastatic neuroendocrine. And so once the liver's super resilient and it grows back, but does the growed back liver is that handle the same stressors as someone that's got, a normal, liver? And so I would tell, John, that anything that would change the quality or quantity of your lung function would mean that you have less lung available to counter what tends to be a relatively vicious respiratory virus. So, but not to say that he's going to take any more or less precautions because of his lobectomy, but that I would definitely say that he'd be the one to avoid, to the extent that you possibly can, exposure, even first degree, second degree, or third degree associations in known people or environments that would have it, like hospitals. Does that answer your question?
Yeah, yes, it does. So Sherry asks, I had carcinoid lung cancer and I have asthma. Will it be an automatic death sentence for me if I get the virus? So Sherry's scared, considering the pre-existing conditions she had.
Yeah, so I would say the answer to that is no, but that's just because if we were to all go to the crap table of life, the odds are in our favor, regardless of the comorbid conditions we have, or our exposure risk, or even our age. So the odds are that no, it wouldn't be a death sentence even if she were to be diagnosed. I think a lot of what we are seeing, and sort of when it peaked, was when people didn't necessarily know what to look out for. We were having them show up much later in the time course of the disease. We were playing catch up in people that had symptoms for a while. And now I think with programs like yours, with the news cycle coming out and people asking questions like that, is that we have a much lower threshold for reaching out to a medical provider. And now I would tell Sherry is that if she were to have even a hint of symptoms, we have testing more readily available. So we are getting to the point where I think it's going to get less scary, not more scary, even if some of the statistics are still delayed in coming out, because people that have had the disease for the last 2 weeks are still either, recovering, limping towards a recovery, or they're succumbing to the disease. So it still sounds, like it's a little bit more of a melting pot than it currently is.
Got it. Thank you. We had a quick question. We earlier talked briefly about PRRT, and we did have a question from Anna just asking what that was. And I do like to take some time during these Facebook Live to, explain any acronyms or any jargon that people may not be familiar with. So could we take a moment really quickly and establish for Anna and anyone else out there listening what exactly PRRT is?
Oh, sure. So PRT, and then Anna, I've got a nice analogy for PRT. So PRT is a receptor-based, so it's a targeted receptor-based radiotherapy platform. So we call it radiopharmaceuticals. And so it is to treat patients with known disease. So they have measurable disease, and usually measurable disease in multiple sites, meaning the liver, the chest, lymph nodes in the abdomen. And the analogy that I use to explain it to people so they understand how it works is that when we image people with neuroendocrine tumors, we use a scan called the gallium-68 scan. And that is like injecting patients with a bunch of little cars that are driving their whole body looking for a parking space on these types of cells. And then like a pizza delivery light, they send off a light and it shows activity so that we then know where the activity is. So that's layman's terms, but it's really that I'm putting in a particle, it's got a tag on it, and it's going to a receptor. So peptide-based receptor therapies are really just taking the same exact car. So it's already delivered the pizza, taking the same exact car, it's taking the gallium-68 particle off, and it's putting a radiation particle. And for the most part, we know where it's going to go because we got the gallium-68 scan. And so that same car drives that radiation particle to the receptor / parking space and pretty much can, use radiation to target, tumor treatment.
And
it's only been FDA approved in the US for probably around 2 years now, but has been used in some way, shape, or form in Europe for probably at least around 15 years, if not 20.
Right. And that's Ludwighera, right?
That's Ludwighera.
Okay, so we also had a question from Jennifer who asked, should Ludwighera treatment be continued at this time? Which we already touched on. If you wanted to, could you answer that really quickly?
Oh, sure. And the only reason so Ludwighera is like using a generic term versus a name brand term. And the reason we use Ludwighera is because in Europe, they will use different types of particles in the same fashion. And the Ludwighera just happens to be the lutetium-177 particle that is FDA approved in the US. So the only radiopharmaceutical that is currently FDA approved happens to be Ludwighera.
Thank you so much. Okay, so we still get some of these questions. We have Jessica that asks, is it safe to go to the hospital for an oncologist appointment?
Okay, so, well, I wouldn't necessarily say that anything is not safe, seeing that most hospitals are taking like over-the-top precautions on every single person coming in the door. But we are all adhering to the recommendations, and then in some states the requirements to see as many people virtually as we can. So people that need medical care are having urgent problems. or for which a virtual visit is not going to be able to accomplish, that by all means come to the hospital. You need to come to the hospital, and there are innumerable precautions being taken both at the hospital level and in our clinic. But that I would say that they have loosened almost every telemedicine restriction across state lines, so that even patients that have their net providers in another state are able to connect with those providers virtually, so that we can try to keep as many people. Once again, it's all unintentional exposure, but keep them out of someplace like a hospital where we need to have the COVID-19 people actually come in and be treated. And so I would say that if at all possible, I would stay out of a hospital, but I don't want you to be so nervous about going to the hospital. If we need to go and see you in clinic, you just need to do that, and we just take all the precautions.
Got it. Thank you. So Melissa asked, are Whipple and splenectomy patients at higher risk of COVID complications rather, based on this type of immunosuppression?
Okay, so that is it. So the Whipple part, no.
Yes.
And then the splenectomy, because before we do a splenectomy on someone, we explain to them some of the additional risks associated with losing your spleen at different phases of your life. So losing your spleen as a child has more impact because you have an immature immune system than if you were to lose your spleen in an adult that has a more mature peripheral immune system. So, but the organisms that we are particularly nervous about in post-splenectomy patients are encapsulated bacterial organisms for which we vaccinate those people. And so viruses are not directly related to splenic, function or lack of function. But all that said, that your ability to mount an immune response is going to be different patient to patient, splenectomy patient to splenectomy patient. So we already tell those patients to have a low threshold for calling their provider if they were to have, an illness that seemed beyond the typical cold, going around. We'd rather know than not to know, because we do have a much lower threshold for pulling patients in like that, because they are post-splenectomy, and we have no way of measuring how well or how they might struggle to mount a response to anything they're exposed to. Got it. Isolated organisms that are particularly and we vaccinate against those prior to or right after the splenectomy.
Okay, thank you. Hopefully that helps Melissa. Everyone else, we have we got about 20 minutes left. So if you're joining us again, let us know where you are in the world. If Dr. Maluccio has been helpful and I have been helpful, send us a thumbs up or a heart and let us know that we're doing a great job. We're here to serve you. If you know anyone that would benefit from this, we still have some time. Please share the link. Just hit the share button on the bottom of the viewer, and let any patients or caregivers or anybody that you know that would benefit from this knowledge know that the video is now streaming. But if they miss it, or you want to refer back to this, it will live here on the Carcinoid Cancer Foundation's Facebook page. You can come back to it. You can refer back to it at any time. We also have a lot of video content here on the page and on our YouTube channel. So check us out there as well. So let's move forward. We still have some questions. We have Sarah, another question about asthma. Any additional recommendations that you have for patients with asthma? Anything specific they should do or look out for or be cautious of?
Oh, well, I think asthma people, or people that have severe asthma, already have kind of the behavior modification and know some of the triggers for their asthma, and will often have inhalers. So I think that now's the time to know where your inhaler is, or you can potentially use your inhaler, but that could very well be because you're in an enclosed environment and we just don't have as much. We aren't even going outside nearly as much as we were before. So you are then prone to some of the dust mites and things that will just be around your house. Or some people's asthma can be triggered by bleach solutions and pine sol or things like that. And so I would say that all of the methods that we're all using to disinfect our close environment are could very well, be making the asthma a little bit worse, but nothing than using the medications that are already prescribed to you and reaching out to, often people are either by a primary care doctor or a pulmonologist, is that there are, if you find your asthma, sort of cropping up a little bit more than usual and it's beyond what is comfortable for you, absolutely. I would reach out to a medical, provider, because any respiratory symptoms right now, we would have a very low threshold for at least keeping you on a radar.
Mm-hmm. No, those are good tips. It's kind of a cruel twist that this is all happening during like allergy season. We all seem to be playing this game of, are these normal allergies or is this coronavirus, which is a game no one wins. Okay. So Helen asks, what about Afinitor? Is that considered an immunosuppressant?
So, well, sort of. So
let's establish what Afinitor is.
Is a biologic. So Afinitor is a targeted agent, unlike cytotoxic chemotherapy, which is more of a myelosuppressive agent. And so we put all those under the umbrella of chemotherapy, even if they're biologics or targeted versus cytotoxic chemotherapy.
Got
so
it.
I think the safest answer to that is that I would categorize Afinitor in the same group of patients that are on active systemic therapy other than just getting sandostatin. And the reason that is that the somatostatin receptor inhibitors don't have an influence on your immune cells, whereas almost every other systemic treatment may very well. So I lump all of those in under the active chemotherapy patients and give them the added recommendations to have a low threshold for calling their medical provider. Mm-hmm. And being the ones that staying away from the risk group that is the asymptomatic or mild symptomatic carriers, like kids under the age of 10, and just being a little bit more conscious of your touch points. What we call the touch points is that we all take for granted how many things we touch, and then we touch our eyeballs and our mouth and our food. And
so much.
And it's just being a lot more diligent without being, a completely crazy person. But I think that we're going to come out of this. One, I think that we're going to be a lot more conscious of it.
Definitely.
I think programmatically, we're going to be a lot better at delivering adequate healthcare, even if we don't have to march them in like soldiers into the clinic setting. And so I think there are a lot of lessons that can be learned from what has been just a surreal experience that we can go back and just learn about a lot of behavior that we have. And, and we all know we're going to get out of it.
Yeah. I mean, that was really well said. You're completely right. And you don't realize how much you touch your face until there's something like this going on, right? Or how many behavior patterns that we have that are could be done a lot better to protect our safety. There's a lot that we're learning from this. I saw
no one will look at a wipe at Target the same again.
Seriously. I saw some meme that was well, now we all know that pretty much all of us can work from home, no matter what your boss says. All right, so we're nearing the end. We still have about 10 to 12 minutes left. So if you guys are out there, which I see our numbers are still up, which we appreciate, go ahead and get your questions in now. We have one from Krista about immunotherapy. Does getting immunotherapy infusions leave you more likely to have a haywire immune response if you become infected with COVID-19, or could immunotherapy help make your immune system stronger?
Oh, so that is also a very good question, Krista. Immune therapy is really about targeting a certain part of your immune system mm-hmm. is known to be altered by whatever cancer it is that someone has. So certain cancers will be tricky in mm-hmm. ability to mask themselves or do something that alters your ability to notice it and or eliminate it or keep it in check. But that is actually not about haywire. So the immune modulatory therapy that we currently have, like PD-1 inhibitors, are just immune modulatory that are trying to then get around that, that type of a checkpoint that is a relationship between a cancer cell and your natural immune system. But if you were to get exposed to something, your immune system's not going to go haywire, and it's not going to, you know, all of a sudden spiral. Now, that is very different than some of the immune therapies that have been used for something like melanoma, where we are stimulating the whole immune system. We are causing a huge upregulation of the immune system in hopes of getting enough army out there to fight off the melanoma. That's different type of immune therapy, and not one that is commonly employed, and definitely not employed in neuroendocrine. So that wouldn't be relevant.
Got it. Thank you. Hopefully that helps, Krista. I have a couple from JJ. JJ asks, I'm coming up on the 30-day mark of waiting to get my shot. Should I try to move my shot locally or go get it in a top hospital in a metropolitan area, or just wait? Okay.
So you kind of have, you know, three choices. If you are symptomatic and therefore vulnerable to having breakthrough symptoms if you miss a shot, I would reach out to your neuroendocrine provider, whoever gives you the shot, and see how they are managing the home delivery of the shot through the two pharmaceutical companies that make, you know, one or the other formulation. Two, if you are not one that struggles with breakthrough symptoms, and people that get that shot know, like 3 days before or 3 days after, is that they will feel that sort of fluctuation as it lulls and then goes back up again. So if you know that you are vulnerable to those fluctuations, I absolutely would reach out and find some other way. But if you're not, I would just hold. It takes, even if we take you off that drug tomorrow, it'll take your body another month, 2 months, 3 months before you would have it drop down, you know, to undetectable in your bloodstream. So if you aren't falling into that vulnerable category, we have just held people's shots and then figured out something else, either someplace closer to home, don't push them into a metropolitan area, try to use the home solution, or just hold off and start the cycle, you know, whenever we start it up again.
Got it. So JJ also has a dog, a sweet, adorable dog that he likes to walk, and he's concerned about, you know, walking outside during this time. Does it increase his risk of getting COVID through the air? And if, or what can he do to lower those chances?
Okay. So if you were to actually read the recommendations, it's not about not going outside. And so even in the people that put in these restrictions really, really early on, like the San Francisco Bay Area, it was about understanding social distancing and the entire concept of social distancing. But it was about getting out so that your whole mental status of being able to get out of the house and not feel quite so isolated or shut in. And so the viral droplets, when we're talking about it, is that they come up with that 6 feet, and you know that it's probably going to be a conservative estimate. And so it's really a lot of people in the same place, singing, dancing, laughing, congregating, you know, over it. And the fact that that's just going to have a natural droplet formation to it, and you're standing, you know, well within 6 feet of each other. But that people are out walking, you know, their dogs. They are out walking their dogs with people that, you know, within their family unit, not necessarily 6 feet from each other, but people where you've controlled that home environment to the extent the end. So you can control your home environment. You just can't control 1 or 2 degrees of separation from that. So you do have people that will wear masks. And so although I don't think the data is super strong that the mask is somehow protecting you from, is going to be the end all be all in protecting you. It's going to be better than not, having a mask. And so if it makes someone feel better, like they are both taking the opportunity to go outside, walk their dog, and do things that kind of give them some mental balance, is if it's about wearing masks, people wear masks, but I don't think you need to call out the next guy that's like, 6.5 feet from you from not wearing the mask, is that's not going to put you at unique risk.
Yeah, that's a great point, because that's a big question with everybody, cancer patient or not, is like, how realistic is the mask? And it's just like, I like how you said, it's like, it's not the end all be all, but it's way better. It's better than not having it, especially if you're someone who's already dealing with something and really concerned about this. I think taking all the precautions possible is a good thing. So, yes, JJ, definitely you can
get out and walk your dog.
Go ahead, yeah, and give that sweet dog a little belly rub from us. But I was thinking about this too. I was talking with my neighbor. I know some areas like up north, it's a little colder, but thank goodness it's kind of in springtime when this is happening, even though there is the pollen and the allergies. But can you imagine if this was in the dead of winter? We'd really be isolated inside and probably going stir crazy. So the fact that we can go outside right now, I think, is keeping a lot of people sane, to be quite honest. You mentioned that the effect on the mental state, being outside in the sun among nature, is so crucial for that, in my experience.
Well, I do. And I think that isolation in the days of social media outlets is very different than even if you were to talk about 30 years ago. And so I do feel like every once in a while, I count that all of those maybe grandparents that have really strong bonds with their grandkids that would be feeling considerably more isolated were it not for some of these virtual media platforms. And so that's why I think that however we can help make it less isolating. And if that's walking your dog or just even sitting on a porch and just realizing that life is going on, around us, and that it's, I don't think we have to take away completely from the richness of everything that life has to offer just because of a fear that things are lurking in the air. It's not that. It's about you touching something that is exposed and then touching your face. Or you're going into an environment that is enclosed with poor ventilation and someone happens to have a virus or this virus. And, maybe it'll make the flu seasons less virulent going forward because we'll all be a lot more diligent. Right.
That's a good point. And I definitely have to plus one that. I mean, in terms of utilizing what we have, connection. I don't want to spend too much time because we have a few more questions, but connection and community is so important at all times, especially when we're navigating psychological or mental health issues. And we all know that those different pillars of health are overlapping. And so it's important for us to stay connected any way that we can. And this is a big part of why we try to keep these conversations going among the NET community. The NET community, I'll tell you, is a powerful one. I've been working in it in 10 years, and I don't know, and I've done a lot of documentaries and projects in other fields of medicine and healthcare. And that's something that I really love about this community, is that people are fighting for themselves and they're fighting for each other. And I really appreciate that. So I would just say, from my experience with connection and community and storytelling, continue these conversations, join these groups, you join the Facebook Lives. This is why we're trying to do that. Besides just delivering valuable information, delivering connection, between human connection is what it's all about. And I'll step down off my soapbox now.
But I agree with you. Amen,
yes,
brother.
I see you nodding your head, so I know I'm saying good stuff. Okay. Let's see. Okay. So Helen asks, can you talk about vaccine development? When is that realistic? And also what she says, when will immunocompromised people be able to go out? Is it until we get a vaccine, or what do you think?
Oh, I doubt that. I think that the CDC I think is just trying to be very cautious about when we lift restrictions. But I think a lot of it has to do that we live in the home of the free and the brave. And so we are not accustomed to someone telling us that we can't go here, we can't go there, or need to do something. And so a lot of it comes down to personal responsibility. So I think that they will start to loosen the restrictions, but I think that they will still have precautions in place probably for, and it's not going to be until a vaccine is, but probably for at least another month. They were just talking about how if we do it too early, they're worrying about a new spike.
Right.
But that I do believe that we don't even understand how rapidly the vaccine type and the testing and stuff like that, like when you really comprehend, go back 50 years and figure out how long it would have taken us to get this far and what we've been able to do in what, like, 6 or 8 weeks. I mean, these people are brilliant. And I think each day we probably get that much closer to finding some, even if it's an overlap in treatment, antiviral treatment. So even if there's some overlap that would be able to blunt the manifestations of the disease, that would be better than nothing. And then obviously, like a lot of viral things, they'll figure it out and they will come up with a vaccine, but that I don't believe that is what we're all waiting for before they will start to allow us to get back to normal.
Got it. Okay, I think we have time for 2 more questions. Hillary asks, lots in the news about ibuprofen and COVID. If we get a fever these days, what type of over-the-counter fever reducer would be best?
So the thing about anti-inflammatories is that they are masking a symptom. So they're just trying to diminish the side effects or the manifestations of that, or the feeling of unwellness or the headache or something that's associated with a high fever. So the taking of ibuprofen or Tylenol is not mutually exclusive to calling your medical provider if you were to have a fever at this point in time. But not to say that they're going to do anything different other than say, okay, you told me that you took it. Keep taking your temperature so that I can understand, is it trending up? Because, we could have a fever for 15 other, sure, reasons, but we're just more diligent about it now. But that all you're doing is you're letting your medical provider know that you've got it. You're letting your medical provider know that you are treating it to try to diminish then that manifestation of it. But they're going to give you all of the recommendations and the follow-up that's going to make sure that you aren't, sort of just popping the ibuprofen over a long period of time and not getting better. And I think the virtual platforms have allowed us to enter people's houses every day, every other day, every week, or have almost a much more real-time communication. And before, when we didn't have any testing, it was just kind of like, well, do this, do that, call me. Mm-hmm. But now the thing that's going to ramp up is going to be the access to testing. And then that person would be able to go to an urgent care center or somewhere and actually be tested to allay some of the fear that the fever or the taking of the ibuprofen is masking something more serious. Got
it. Perfect. Well, that leads nicely to our next and final question. Stephen asks, it's not uncommon for me to keep a low-grade fever. I have a 99.6 right now. No other symptoms than fatigue and intensified diarrhea. Would it be wise to get a COVID-19 test?
Okay, so there's sort of the recommendations. So they were saying, okay, if you have this, then in the 5 questions, and we all get the 5 sessions every morning when we come into the office. And so they're starting to loosen some of those things where you don't necessarily need all 5 to be positive in order to ultimately get triaged into the testing thing. But that when we talk about fevers associated with this, it in general is not a low-grade fever. They were talking about fevers up into the 102, 103, like noticeable fevers, even when you didn't have the respiratory manifestations of it. And so really a fever is all going to be relative to a human being. And if that person knows that they run a 99.6 and they take their temperature over the course of a day and it stays somewhere around 99.6, well, then the odds I put my $10 on it not being COVID related. But if that person was all of a sudden to start running 101 and or have a 99.6 with respiratory things, is that then you alert your medical provider, and then I'm sure we're going to have a new list of triggers that would prompt a rapid test or a 3-day test as those become more readily available. And I think those are going to become more readily available probably in days to a couple of weeks, not like we're waiting another 30 to 45 days for that to become available.
Good to hear. Good to hear. Okay, well, thank you. That wraps it up for our session. Dr. Maluccio, I appreciate your time so much. Do you have any parting words for NET patients that are worried? We've got this pandemic going on. We're all worried, but especially people that are already fighting a fight. Any final words you have to say that will help them with any of those fears or concerns?
Yeah, I just think that that fear is a reality. So we'll fear what's going to happen to us next year. We'll fear what's going to happen to us when we're 80. So fear is a reality, and it's about how we cope with that fear. And what I think is really awesome and unique about neuroendocrine patients is that they do have access to a national, if not international, support network, and they tend to be extraordinarily proactive. So they are less likely to then be the ones that say, I think I'm going to blow this off. They are more likely to say, I don't think I'm going to blow this off, or reach out to someone on Agave or something and say, hey, what this, and then someone's going to say, oh yeah, I've been watching the Carcinoid Cancer Foundation videos, and I got the impression that you should just at least alert something that you're having these symptoms. But I do think that any crisis, whether or not it be a cancer crisis, a treatment crisis, a virus crisis, a family crisis, or something like that, it's really a time for us to really reflect on all of the blessings that we have, and not get so bogged down in the fear of it all, because I think that we just had too much information. It was thrown at us all at the same time, and then we had just scary stuff happening in Europe, a lot of mixed messages coming from the news outlets, and so it was just really hard for people to get a grip on it. And I think that now that we are 30 days, 45, however many days we're into it, I'm hopeful that people will have either learned how to cope with that uncertainty better, have found outlets to help them cope with that uncertainty better, or are realizing that we are going to ultimately get out of this.
Awesome. I appreciate
my words of not very much wisdom.
No, total wisdom. I appreciate your time. Thanks for making time for us today. And thank you all out there who joined us. We appreciate you so much. Our goal is to continue to educate people and spread awareness about this disease. And we're just so grateful for the community that has come around Carcinoid Cancer Foundation, and appreciate you all being here. If we didn't get a chance to get to your questions, again, I encourage you to reach out to the Carcinoid Cancer Foundation. You can send us a message here on the Facebook page, or you can visit carcinoid.org, and they will do their best to direct you to the right information. Big thanks to our presenting sponsor, Lexicon Pharmaceuticals, for making this COVID-19 weekly Facebook Live event happen. And join us next time for the Facebook Live series. We will be back next week on Monday, I believe, but pay attention to our social media. We will have an official announcement soon. Dr. Maluccio, thank you so much. Be healthy, be safe. We appreciate your time.
Thanks, Rain. I appreciate the opportunity.
Bye, everybody. Have a great day.